सर एक अनाउंसमेंट कर दो, डॉक्टर मोहम्मद हुसैन का बैग मिसिंग है बाय मिस्टेक.
So good morning to all of you. One bag is missing, Dr. Muhammad's bag. So if anybody found the bag, please return to him. So, or maybe mistakenly exchanged by your bag. So today I am going to discuss the disadvantages of laparoscopic surgery. Yesterday we have discussed the advantages of laparoscopic surgery, and we came to know that there are a lot of advantages, that is improved diagnosis, less tissue dissection disruption, less infection, less adhesion, faster return to work, less pain, less immunosuppression, and cosmetically better outcome. Other small advantages like the early recovery and return to work, those are related to less disruption and tissue dissection. So those are smaller advantages which is because of the less tissue dissection and disruption. Today I am going to discuss the disadvantages of laparoscopy and contraindication of laparoscopy, that in whom laparoscopy should not be performed. That is very important. So one of the most important disadvantage of laparoscopy, that it is more expensive. If you want to become richer after doing laparoscopic surgery, it won't be possible. It will make you poor. And who is getting rich? Someone sitting in America is getting rich. You will get no benefit of financial in laparoscopy. Reason is why? Because initial starting cost of the laparoscopic surgery is minimum 25 lakh rupees. That is minimum 25 lakh. Maximum is going up to 2 CR, but minimum is 25 lakh. So in 25 lakh what you will get? Simple HD camera, telescope, light source, light cable, simple bipolar and basic instruments. After that you will earn for 6 months, 1 year, they will come with a harmonic scalpel, and then again your 18 lakh rupees is out. And after that recurring cost of the harmonic probe is already there. Then you will earn again, they will come with a ligature, and again your 10 lakh rupees is out. Again you will keep on earning, they will come with a thunder beat, again 20 lakh rupees out. Again you want now hysteroscopy with a better option, then they will come with the Versa scope, Versa point. Versa scope is a 1.8 mm hysteroscope, and Versa point is a hysteroscopic bipolar generator. So that will again cost you around 18-19 lakh rupees, it is out. Then you start myomectomy, the storage modulator cost you 11 lakh rupees, that will be out. So you keep on earning and keep on buying, there is no end. And after 5-10 years you have a bumper, very good roaring practice, then they will come with your robot, that is Da Vinci 5, and your 30 crore rupees is out. Da Vinci 5 costs you 30 CR. And then you have a big loan which you will keep on giving EMI throughout the life. And already I have told you yesterday that you have more coronary artery diseases, more stress, and early retirement. You will retire early. So actually laparoscopy, by some of them, they considered laparoscopy as a conspiracy against common man. And basically surgeons are exploited. Who is becoming richer? Who is making the technology? Someone sitting in America is deciding how much money you have to take from the patient. This is a big problem. And this problem is slowly increasing more and more. Second big disadvantage of laparoscopic surgery is that more operative time. For the beginners, it takes 50 to 60% more operative time, but it was found that with the time it decreases, and at least 30% extra time will be taken by laparoscopy compared. So if the patient is hemodynamically unstable or in the shock, laparoscopy is dangerous because your operative time cannot be tolerated by the patient. Third big advantage is potential for major complication in inexperienced hand. In the open surgery, even the first year resident, you can tell him to assist, and he will hold your suture, he will catch the seizures, and he can help you. But in laparoscopy, it is not possible that inexperienced hand will help you, because there should be a separate learning curve, separate experience. And if you will push anyone that you have to do laparoscopy, it may turn into disaster. And this is one disadvantage, that especially you have to learn the laparoscopy separately. So this is potential for major complication in inexperienced hand. Third disadvantage of laparoscopy is loss of tactile feedback. In open surgery, our finger is our third eye. A lot of pathology you can palpate, like when you are doing the large myoma removal, then you, with the finger, a smaller myoma also you can palpate, and with the same incision, those smaller myoma you can take it out. In laparoscopy, there is no way to remove sub-centimeter myoma. Sub-centimeter means less than 1 centimeter, because there is no tactile feedback, and we are bound to leave it, because you cannot palpate. Just like today you have seen, we were doing dermatologist and one small dermat was also there. In open surgery we could palpate it and we can feel, oh, this is also a laparoscopy. Only you have a visual interpretation, so it may be missed the pathology. Like you are doing the cholecystectomy and some stone slipped into the CBD. In open surgery you can milk it back to the gallbladder. In laparoscopy there is no way. You are doing mucinous cystadenoma of the ovary, and in mucinous cystadenoma of the ovary, many a time primary source is the appendix, and suppose appendix should give rubbery feeling. If you will press the appendix, it give you like a rubber feeling. In laparoscopy, how can we decide the rubber feeling? Not possible. In robotic, you have a haptic feedback. This is called haptic feedback. Haptic feedback is a software generated feedback. This is haptic. And in robotic, what happens, that when you are using master controller, and if one instrument hit, your instrument vibrates, zzz, zzz, vibrates, and color changes. Just like when you are playing video game and one car hit another car, your console vibrates, and that kids are enjoying. They think that it is really hitting one car or another. Same way in robotic, especially Da Vinci 5, it has a very good force feedback, real tactile feedback. It gives you the sensation by software. But in laparoscopy, we don't have either haptic and not original. So this is the another drawback. Like colon cancer, in open surgery you can palpate the tumor, and then you can decide that 10 centimeter proximal, 5 centimeter distal, I will remove. In laparoscopy, total colonoscopy and tattooing of the tumor should be done prior to the surgery, so that once it is tattooing is done and colonoscopy, then you know, oh, this is the part I have to remove. You cannot take any new decision by palpating the tumor inside the abdomen. So this is a big drawback. Another drawback of laparoscopy is challenging when skill development is less. Like here, surgeon is using intracorporeal suturing, and this is the surgery which is called pectopexy. So using mesh to fix the cystocele, and bladder is separated, and this is uterus and cervix fixing the mesh. And this is a wrong method of suturing, because practical skill development was not done. Surgeon has self-learned the laparoscopy. Remember, in laparoscopy, any time when you are doing suturing and you are tying a knot, you should never ever hold the suture, hold the needle to take a wrap. He is holding the needle to take a wrap. Another big mistake, always hold the suture, never hold the needle. Another, that right hand should take a wrap around the left hand. He is taking the left hand to take a wrap around the right hand. This is one other mistake, and he is using needle. And another third mistake is, when you are tying the knot, you should never use needle to slide the suture. He is trying to take a needle to slide, and it is prick the iliac vessel. And now this patient is going to die. There will be mortality. Do you know why? Because this is called triangle of doom. This is triangle of doom, and this is the iliac vein which is punctured. Immediately you have to take it out, and you have to ask your vascular surgeon. You have to call the vascular surgeon, because you don't have an idea how to repair this iliac vessel. And once you call the vascular surgeon, he may not be free. He say that, madam, you do something and I will come tomorrow, or I will come after 1 hour. Within 1 hour, your patient BP is sinking, hematoma becoming so huge, and you have never repaired any. And this is the vessel which you cannot coagulate because it is supplying lower limb, and it cannot be applied any clip or anything. Doesn't happen. You know, in the artery, this vein is medial, artery is lateral. Artery, if it is punctured, it is easy because if you give pressure for 10 minutes, muscle contract and stop. Vein doesn't stop, and it is dangerous. So you will leave the patient and you will ask your anesthetist that call immediately vascular surgeon. I don't know what to do now, and you have left the surgery, and the team cannot left the surgery because team are stuck there. Camera person is stuck there, anesthetist is stuck there, and you are fed up and calling again phone call to the consultant vascular surgeon, and he is busy or he may not be coming, and you are upset. You think that earth should split and my existence should vanish because I don't came in the planet earth, and because no consultant, no surgeon or gynecologist can see the patient sinking in front of your eye. And it is one of the worst time of the any consultant where patient is going to the shock and he cannot stop. This situation generally in open surgery doesn't happen. That's why it is called a skilled surgeon, safer surgery. Laparoscopy is not a specialization, it's a skill. Just like dancing is a skill, the singing is a skill, playing a guitar and playing a sports, tennis, football, these all a skill development. So you have to develop, otherwise you will be in trouble sometime. So this is another challenge of the laparoscopic surgery. Now we will discuss some of the contraindications of laparoscopic surgery. One of the biggest contraindication and most important contraindication is severe chronic obstructive pulmonary disease or cardiac. This severe word is important. In severe chronic obstructive pulmonary disease or cardiac disease, you should not perform laparoscopy. Like a patient who has the coronary artery bypass surgery done in the past, or the stent is applied, or valvular disease is there, or COPD like tuberculosis, bronchiectasis, severe bronchial asthma, you should send for the stress echo and the pulmonary function test. Normal echo will not work, a stress echo should be done. And if a stress echo ejection fraction is less than 40%, laparoscopy is contraindicated. If patient is cardiac compromised, then you should send for the advice of cardiologist that fit for laparoscopy, and cardiologist opinion is required, and if he will give fit for laparoscopy, then only you should perform. And same is for chronic pulmonary diseases. Question is why? Problem is not with the laparoscopy, problem is with the pneumoperitoneum. And the gas which we put inside the abdomen has 4 major drawbacks. And that's why laparoscopy is difficult in COPD and cardiac disease patient. First, decrease venous return and cardiac output. Second, decrease tidal volume. Third, decrease creating hypercarbia, and fourth is air embolism. These are the 4 major drawbacks of the pneumoperitoneum. So I will show you how to get rid of these and why these major drawback happens and what is the reason behind it and how to correct it. Do you know this study was performed in the John Hopkins Hospital? In John Hopkins Hospital, what they did, in a large animal, they put the pneumoperitoneum and they observed that how the vitals are behaving. So in the first group of the animal, they used 6 millimeter of mercury pressure, CO2, and they observed for 24 hours all the vitals, and all the vitals were normal. There was no problem. Tidal volume, BP, pulse, respiration, everything is normal up to 24 hours, 6 millimeter mercury. Why? Because our vena cava pressure is 6 and CO2 pressure is also 6. So there was no change in venous return. no change in cardiac output, and that 6 millimeter mercury pressure diaphragm also can nicely tolerate, and it was good. But at 6 millimeter there was no space in the abdominal cavity to perform any surgery. Pressure was increased to 12 millimeter in the second group of the animal. Once 12 millimeter pressure was increased with the CO2, then there was 3 hour it was used, and there was 20% reduction in the cardiac output. Decreased 20%, cardiac output was decreased. And why it was decreased? Because of pressure over the vena cava. And once, because CO2 is not only lifting the abdominal wall, it is pressing the vena cava also, and 20% reduction. But this 20% reduction also vitals were normal, because healthy animal or healthy human can tolerate this 20% reduction. In the third group of the animal, they increase this 12 to 18 millimeter of mercury pressure and CO2, and within 3 hours animal was 40% reduction in the cardiac output, 40% CO was reduced, and then there was unconscious because of hypercarbia, CO2 concentration in the CO2 increases. And in the fourth group of the animal, they use 24 millimeter mercury, and in 24 millimeter Hg there was death. In 3 hours animal died and death was there. Why? Because there was 80% reduction in the cardiac output, 80%. So no survival, dead. So ideal pressure is 12, maximum 15, and very much, suppose you have a problem with the vision, maximum 18, but ideally 12 to 15 is the ideal pressure, because this 20% reduction in the cardiac output a normal human being can tolerate. We don't have a problem. But suppose already I am cardiac compromised person because of any heart disease, then this 20% may be dangerous. So that's why a patient who has COPD and cardiac disease, you should not do laparoscopy. In the John Hopkins Hospital itself, in the same study, they have seen that how it behaves once the patient has the same thing, how it behaves if the patient has this on the tidal volume. And what they saw, that tidal volume also behaving different way. So tidal volume, you have to be careful. Like here, what is our normal tidal volume? Normal tidal volume is 500 ml. Yes, 500 ml. And when the first group of the animal was used, that has the 6 millimeter mercury pressure, then there was no change in tidal volume. No change. Tidal volume I am writing TV, no change. At 12 millimeter mercury pressure, there was 50 ml decrease in the tidal volume, decrease in the tidal volume. So remaining was only 450. And in the 18 millimeter of mercury pressure, there was 150 ml decrease in the tidal volume. So remaining was only 350. And in the 24 millimeter of mercury pressure, surprisingly, there was 300 ml decrease in the tidal volume. So remaining was only left was 200 ml. So you can understand that if 150 ml tidal volume is decreased, and suppose 50% of the lung is already diseased because of tuberculosis and bronchiectasis and other problem, then patient will go to acute respiratory distress and we can lose the patient. So patient has a tuberculosis and 50% lung is diseased, remaining 50% he was compensating anyhow, and that decrease in tidal volume can kill the patient. So that's why any patient who has COPD or cardiac disease, is contraindicated in laparoscopy because of decrease of the venous return and decrease in tidal volume. These are the two main factors. So we have to consider. Now, third drawback is hypercarbia. CO2 has one big problem, and that problem is that it is 200 times more absorbable than oxygen. 200 times more absorbable. So it easily get absorbed in the plasma because peritoneal membrane is a semi-permeable membrane, and through that peritoneum diffuses and plasma will absorb it, and then it creates hypercarbia. And once this hypercarbia forms, then it crosses the blood-brain barrier and enters into brain. And brain is very sensitive to the CO2, and then it gives command to the cerebral artery, and there will be cerebral arterial dilatation. Cerebral arteriolar dilatation. And due to that, what happened? There will be cerebral edema. And once cerebral edema develops, then the brain give command to the heart that I am in pressure, decrease the heart rate. So there will be bradycardia. And this bradycardia will result more hypercarbia. Because previously suppose 70 times blood was crossing through the lung, now only 60 times it is crossing. So CO2 cannot wash out and it will be more hypercarbia, and then ultimately there may be death. And if death happen, then they will inspect that you have a capnograph or not. And not having capnograph, what capnograph does? It is measuring EtCO2, end tidal CO2 concentration. And not having capnograph in laparoscopic multi-para monitor is a medical legal issue. And your anesthetist has a duty that in his anesthesia sheet, every 15 minutes EtCO2 level has to be written. If you have a EtCO2, this bradycardia, hypercarbia and cerebral edema will not happen. So suppose he is measuring the EtCO2. EtCO2 means at the end of tidal volume, what is the CO2 concentration. You know, normally also our EtCO2 is below 20. Right now also if someone will measure our EtCO2, it will come below 20 because we ourselves is producing always CO2. And if you started running fast, like suppose fright and fight mode or marathon races or vigorous jogging or gymming or exercising, our EtCO2 go to 50. That's why you might be feeling some pulsation inside your brain. You will feel some pulsation is inside and you feel like a warm inside your brain. But at that time, body is doing one preventive mechanism. What body is doing? That our body secretes adrenaline in fight and fright mode and in vigorous exercise mode, and that adrenaline is creating tachypnea and tachycardia. So it doesn't allow this hypercarbia to do bradycardia because adrenaline will compensate it, and we have a tachycardia and tachypnea and our pulse rate become 120. Why? Because we want that CO2 washed out, and then we go to the normal stage once CO2 get washed out. But anesthetized patient cannot go to tachypnea and tachycardia, so they go to bradycardia. So once the EtCO2 is 20, it's good. If it is 30, okay. If more than 30 EtCO2 is started, then anesthetist will tell you that madam, please reduce the pressure. You will say why? Because EtCO2 increasing. So suppose you were working on 15, you should decrease to 12, or if you are working on 12, then decrease to 10. Because amount of the absorption through the peritoneum also depend upon the pressure gradient. If you use more pressure, absorption will be faster through the peritoneum. So you will decrease the pressure, and what he will do? He will increase the rate of ventilation. That means what? He is doing tachypnea, artificial tachypnea, and sometimes he give a very low dose of adrenaline so that there will be tachycardia. So basically just like our fright and fight mode, he is inducing the tachycardia and tachypnea, and then EtCO2 decreases. But suppose then also EtCO2 is not decreasing and still it go 40 or 50, he will tell you to stop the surgery because this patient is not tolerating CO2 and he will become unconscious, he will get cerebral edema, so please do open. And how he can find out? By EtCO2 in the monitor. Tomorrow I will show you in the multipara monitor, you will see EtCO2 is written there, and that is why it is important that you should have. Now this hypercarbia in the COPD or cardiac patient happen more because their heart is and lung is already diseased. So they are more prone to accumulate the CO2. Normal lung can eliminate and it can excrete by expiration it can take the CO2 out. But the diseased lung will accumulate the CO2 and chances of going to hypercarbia is high. And that is why any patient with the COPD and cardiac disease, severe COPD or cardiac disease, contraindication of doing laparoscopy. So why? First is decreased venous return and cardiac output, second is decreased tidal volume, and third is chances of going to the hypercarbia. Now the question is there any good gas which we can use instead of this CO2? CO2 is creating hypercarbia, so is not we have alternative? The scientist has tried many alternatives. First alternative of CO2 is very good, that is called helium. And helium is creating less cerebral edema. If CO2 create 4 plus CO2 create 4 plus cerebral edema, then helium create only 1 plus cerebral edema. So it is very good. It is also inert. It is also anti-combustion. It does not promote the fire, and it also is highly absorbable CO2. But the problem is cost. It is very expensive. You know, 1 kg CO2 in India is costing you approximately 150 rupees, if I remember correctly, but around 150 rupees. Our staff, they know better. And 1 kg has 22 liters CO2, depending upon the pressure, because it is liquid CO2, it is pressurized. So 1 kg helium will cost you around 5,000 rupees. And you know, in one surgery, approximately 3-4 kg is used. So suppose 4 kg means you will have 20,000 rupees will be the cost of helium only. And it is not like that, it does not create cerebral edema, it creates less cerebral edema compared to CO2, and it is not easily available also. So some of the hospital like Mayo Clinic or Cleveland Clinic, some of the VIP patients, they use helium and it works fine, better than CO2. Now second alternative is nitrous oxide, that is N2O. Nitrous oxide is also very good gas, alternative of the CO2, and it is also highly absorbable, and cerebral edema is again 1 plus only compared to CO2, but the problem is it is combustible. So you know, it can easily, it is inflammable, and so you are not allowed to use monopolar, bipolar. For diagnostic laparoscopy it is good, it has one big advantage, it creates analgesic effect also. So Mishra, once it comes with the contact with the nitrous oxide, it will be very smoothly anesthesia work, and it is highly absorbable. Only precaution is that if you are using in Boyle's apparatus also you are using nitrous. Normally in Boyle's apparatus anesthetists they use 40% nitrous oxide and 60% oxygen. But once you are putting nitrous in the abdominal cavity, then in the Boyle's apparatus nitrous oxide should be only 20%, because remaining 20% is absorbing from the peritoneum also. So patient should not be over anesthetized. So you have to decrease. And another, you don't have to use the electrosurgery, means any spark should not happen. For diagnostic it is great. For the surgery where energy sources is not required, for gynecologists it is very good. No shoulder tip pain, because it doesn't irritate the diaphragm, it doesn't make acidic environment. And this is the another gas. Third gas which is used is air. Air has the chances of air embolism. Air embolism. And it is not creating cerebral edema, but it is creating very high 4+ chances of air embolism. And it is medico-legally illegal to use air for the insufflator. But unfortunately in developing country, in many of the small setup, they use air insufflator. Because in a small village level CO2 is not available, air insufflator jaldi se le jao, and it may be expensive or it is not easily available, then they use air insufflator. In India, unfortunately, in tube ligation camps, they use ambu bag to put room air inside the abdomen. Insufflator वगैरह नहीं होता है. So what they do, they direct trocar and attach the ambu bag in the trocar, and room air they push it. And air embolism chances are there, because in John Hopkins Hospital they did one study that they injected the various gases in the abdomen of the animal, vein of the animal. And what they did, in the first group of the animal, they injected oxygen to see what oxygen behave. Do you know, if you will put 20 ml oxygen in the vein of someone, he will die. There was one Hollywood film, I don't remember the name, where the nurse was criminal and she was bringing all her enemy to the hospital, and at night in the syringe she was taking oxygen and slowly injecting in the vein, and the morning patient will be found dead. So if you want to kill anyone, just load 20 ml oxygen and put IV, he will die. Because oxygen is very badly absorbed gas, it isn't absorbed. And that's why our circulatory system need hemoglobin to carry the oxygen to one place to another case. And once directly IV oxygen is given, then that much hemoglobin is not present at one place. So oxygen will remain as a bubble, and this will go and it will create air embolism. In the second group of the animal, they use air. If you want to kill someone by air, you need 200 ml air and 200 ml. But third, they use CO2, and CO2 up to 2 liter is safe. Even 2 liter CO2 you will inject in the vein of someone, he will not die, because CO2 get dissolved in the plasma. That's why in the varus needle mode, in the insufflator, for safety we keep 1 liter per minute. This is the only reason, that accidentally if our varus needle is any vein, and as long as 1 liter gas is going into the vein, patient will not have air embolism. So that's why CO2 is used. CO2 creates hypercarbia, it creates irritation of diaphragm. But why CO2 is loved by everyone? Because it is highly absorbable gas. It gets absorbed so quickly that it doesn't create air embolism. So air insufflator, if you are using, it is a medico-legal issue. Now the fourth gas which is there is called xenon and argon. Xenon plus argon, these are the gases which is also used for pneumoperitoneum, pneumo. And some of the center, they have started using xenon and argon. They are also highly absorbable gas, inert gas, and it is good. But again, cost is a factor. And another factor, you have to use only harmonic scalpel. You cannot use monopolar, bipolar, because these are the only two gas which is ionizable gas. Ionizable means it can take electron from one place, it can transfer to another place. So if you will type in the Google that xenon pneumoperitoneum, peritoneum, then you will see some of the literatures they say that xenon can be used as a pneumoperitoneum in the abdomen, and primarily creating a space in the laparoscopic cavity they use it, but xenon pneumoperitoneum. But xenon anesthesia for laparoscopic cholecystectomy, they have seen that it is good, but some of the studies say that argon and xenon is not as good as CO2 because it creates the electron, but some people they use, and another gas is argon. This is argon pneumoperitoneum. Argon pneumoperitoneum is also used to abdomen during minimally invasive surgery. Hemodynamic effect of argon pneumoperitoneum. But some of the studies say that argon is more dangerous than CO2. Why? Because it creates and it is also ionizable gas. So ultimately altogether what you will see that only gas which is safer all over is our CO2, because CO2 is easily absorbable, CO2 is highly absorbable, CO2 is cheaper, and you can find out. So among all the best is CO2, after that helium, and the third is nitrous. Air and xenon is not recommended, but unfortunately it is used. So I am showing you here that I have this air insufflator, and these air insufflators are available. Unfortunately, ideally government should ban those insufflators, but government has less regulation on the insufflators. You can see this is the insufflator which is available, and here you can see that gloves leke आओगे ना, this is the okay. So here I am pressing it and you will see it will show you, and here it is writing air. You look at this, it is writing air, and then I am starting the flow, and you can see it has a beautiful pulsatile flow. As soon as I attach, see, and it is insufflating, and this gloves is like abdominal cavity, it will distend, and it also has actual pressure. Preset pressure is 15, and you will see once the gloves will distend, then actual pressure will slowly increase, and it will measure the actual pressure. Now see, this actual pressure is increasing, and once actual pressure will reach to preset pressure, it will stop, and it is warming also, CO2, and it is air. So people they love this insufflator because it is a one time buy, and after that you don't have to buy any CO2. And in reality, incidence of air in embolism is 1 into 10,000. So 10,000 में एक मरेगा, and that is acceptable number in India. 10,000 में एक ही ना मरा. But it is not acceptable in America. That due to our negligence, even 1 in 10,000 if he die, it will be a medical legal issue. But here in India, utna to chalta hai, and that will do the job. So don't buy any air insufflator, it will create air embolism. So these are the 4 major risk factors. Now, CO2 also create air embolism if it is more than 2 liters per minute going. So that's why you have to be careful that it should not happen. Now, how it create air embolism and how it affect in the patient who has a COPD and cardiac disease. What happened that this is the heart, this is the right atrium, this is the right ventricle, this is the left atrium, this is left ventricle. Here we have the arc of aorta, and here we have the pulmonary artery going, and this is the lung, either side of the lung. Now what happened, this is the vena cava, and what happened, this air bubble, because you have used various needles. Remember, air embolism happened due to 2 routes. First route is direct various needle entering into any vein, and second you are doing extensive dissection, and one of the vein is open, like you are doing myomectomy or liver resection or partial nephrectomy or severe endometriotic dissection, and radical hysterectomy and one of the venule is open and your pressure is high, directly CO2 started entering into vein. And if the rate of the CO2 entry is less than 2 liter, no problem. But suppose you are using air insufflator or your flow pressure is high and entry is more than 2 liter, then this air bubble enter into right atrium. After that it will go to the right ventricle and then it will go to the lung. And there are pulmonary arteries in the lung, 3 pulmonary artery. This will enter into any one of the pulmonary artery and it will block that pulmonary artery. And due to that block, this area of the pulmonary area will get infarction. And due to that blood is not entering into this area, there will be pulmonary hypertension. And then hemodynamically unstable and you will lose the patient. Now here you have to be a lot of question face. First, because these questions are very important to remember. First question is, how you will diagnose that my patient is going to air embolism? How you will diagnose during surgery that my patient is in air embolism? Pardon? SpO2 decreases, but that can decrease even in the DVT, that is thromboembolism. Am I right? So another is something more. Pardon? No, that is another. You know, most important sign of getting air embolism is sudden collapse. BP, pulse 0. Pulseless patient, BP 0, no BP. This is the only condition during laparoscopy where patient will suddenly collapse. Collapse means not dead. BP and pulse is not measurable. Yes, that is the second. I am coming, you are correct. So it is a sudden collapse. Why sudden collapse happen? Because this is a pulmonary valve, and once this air bubble come to the valve, suddenly all the blood which was pumping will drop down and no blood can be pumped by the right ventricle. Have you seen the water pump in the village? If this water pump has taken the air, then all the water column will drop down. And then you keep on pulling the water pump, the water will not come out. Because your valve of the water pump has taken air. You have a diesel generator in your house. If your tank is free from completely empty from the diesel, then that generator will take air. And merely adding the diesel, your generator will not start. You have to call the mechanic. He will open the tubing and remove the air. And then the generator will start. So this is the first sign. Do you remember? Even if you perforate the aorta with the trocar, patient will not suddenly collapse. Tachycardia will happen first, and slowly BP will fall. Like 120 become 110, then 100, then 80, and slowly and pulse is rising because patient is collapsing due to hypovolemia. Am I right? But in this case, sudden collapse happens because once air bubble enter to the valve, no blood is pumping at all. And as he has correctly told, another you should take a stethoscope and put on the right second intercostal space here. And as soon as you put a stethoscope, or you or your anesthetist, you will hear a mill wheel murmur or water wheel murmur. This is called mill wheel murmur or water wheel murmur. What is this water and mill wheel murmur? You will see what your AI is doing. AI is saying that mill wheel and water wheel murmur, two names for the same splashing sound caused by air bubble in the heart chamber, most often large intracardial air embolus. What happened? That have you heard a sound in your bathroom or shower once your water tank is going to be empty? You are taking a shower and you sound comes. Why this sound comes? Because no water in the tank. And air is coming followed by little water. And little air again coming, that is called a splashing water sound. This type of sound. Why? Because you have air bubbles, large air bubble in the heart chamber. Yes, like a mill wheel or water wheel murmur. And if you diagnose it, in DVT, patient doesn't get sudden collapse. Why? Because this is a clot, and this clot will block one of the pulmonary artery. It cannot block all the 6 pulmonary artery. Am I right? Because simultaneously all 6 clot cannot come and it will clot all the either side of the lung. But once the air bubble comes, it collapses at the level and in the chamber itself it collapses. And EtCO2 decreases. In DVT, in hypercarbia, EtCO2 increase. Here it will suddenly decrease. It was 30, it will become 5. Why? Dead patient EtCO2 will be what? 0. So no blood is going to both the lung. So EtCO2 suddenly decreases. Water wheel murmur starts. And if you are intelligent, you can save your patient within 1 minute. What you have to do? That have you seen the old motorcycle? A scooter, Bajaj or Lambretta? If it doesn't start, what they do? They turn it to one side, tilt it for couple of minutes and then they kick. It starts. Why? Overnight it was idle, so there is a air bubble in the carburetor. And once you tilt it, the petrol comes and air bubble go away, because by default always air bubble goes up and liquid goes down. So what you have to do? You have to remove all the instrument. Don't remove cannula, only instrument. Switch off the insufflator, deflate the abdomen and turn the patient towards the left and fully head down. As soon as you turn the patient towards the left and fully head down, now this blood will come at the level of valve. This blood will come at the level of valve here. This blood has come here. And as soon as blood comes, pulse will resume. An air bubble will go here, it will go to the apex of the chamber. An air bubble which was going from the vena cava to the right atrium will remain in the vena cava, because head is down. So air bubble cannot go towards the heart. And once you turn to the left, this right atrium air bubble, right ventricle air bubble come in the right atrium. Because bubble always go up. We can see here I have this water and here is a air, it go up here. This is air. If I will do, air is here. Yeah, I will do, air is here. So air always go up. So once air goes up, your pulse will come. BP, feel. Patient survive. And if you do any delay in diagnosis, patient will get brain dead. Because ventilation is already there, so heart will still keep on working for some time, but oxygen supply of the brain will come, patient will become brain dead, patient will go to coma on the ventilator. So air embolism must be diagnosed very soon, very immediately, and first is that decrease the EtCO2 and sudden collapse and water wheel or meal wheel murmur. This condition doesn't come in the DVT, it is just because of the air in the chamber. So if the patient who has a normal patient, they don't have this problem much. But a patient who is already cardiac disease and respiratory disease, their chances of getting air embolism is quite high. And that's why these four risk factor, major risk factor, we should not use the, laparoscopy in the patient who has severe COPD or cardiac disease. We should take the cardiac clearance or stress echo or your pulmonary function test should be done. Next contraindication is grade 2 or grade 3 shock. If the patient has suppose postpartum hemorrhage or abnormal uterine bleeding, or due to any reason she is going into grade 2 or grade 3 shock, laparoscopy patient will go to irreversible shock. Irreversible because patient has already shock, and once you put CO2, venous return will be further decreased, and due to that decreased venous return, patient will go to irreversible. So those patients, they need resuscitation, they need the CPR, and you are doing laparoscopy, it is dangerous. So you should not do a patient who has a grade 2, grade 3 shock. Like suppose patient has a rupture ectopic and already 2 liter blood is inside the abdomen, and patient is going into shock. Young patient has one very good thing, that their compensatory reflex is very high. They will compensate. You will see patient will come smiling and talking with you. She will sit on the side of your stool and she will tell that ultrasonologist is saying that something rupture is there, and you will say, and suddenly you will say, okay, surgery is required, immediate, and she will delay, let me think, I will talk to my husband. By the time you see, she collapsed and died. Sudden collapse happened. So any patient who has this type, immediate surgery. Otherwise, if grade 1 is not a contraindication, grade 2 and grade 3 is a contraindication. Next contraindication of patient is the generalized peritonitis. Remember, Boy has given one Boy prognostic parameter. According to Boy prognostic parameter, the time of the perforation is, suppose there is a taphoid duodenal perforation, then time of the perforation should be less than 48 hours. The age of the patient should be less than 35 years, and the diameter of the perforation should be less than 1 centimeter. Then laparoscopic prognosis is good. But suppose there was already a duodenal perforation, taphoid, tubercular perforation, and patient came after 4 days, laparoscopy should not be performed. Why? In cases of severe generalized peritonitis, hypercarbia increases 4 times more. Hypercarbia. Why? Because inflamed peritoneum absorbs CO2 4 times faster. Another big problem is bad vision. You have a very bad vision. Bad vision because inflamed peritoneum absorb all the light. Peritoneum act as a semi-permeable, it is a very good reflecting organ, just like a reflector of a torch. And once our light go to the organ will reflect back, and this peritoneum will reflect again back to the organ, just like reflector of a torch. Or if you go to take a photograph in the studio, they put some umbrella in front of you. Have you seen that? What is the purpose? Light should again reflect back to your face, and you have a homogeneous light on your face. So this happened due to healthy peritoneum. Now this diseased peritoneum is red color, inflamed, absorb all the light. Third problem of generalized peritonitis is fibrinous exudate. This fibrinous exudates means white curd-like deposition, what you are seeing. Those are sources of interbowel loop pus pockets. Have you seen in the tubercular perforation, general surgeon must have seen once you do laparotomy, white flakes are there, which is keeping bowel adhered each other. Those fibrinous exudates are making the interbowel loop and the pus pockets, that is very difficult to remove in the laparoscopy, and there may be perforation. So, and fourth is cardboard rigidity. This cardboard rigidity and adhesion of the organ to the bowel and abdominal wall create more chances of perforation. So, due to that, generalized peritonitis, delayed generalized peritonitis is contraindicated. I am not saying that if appendix get perforated, don't do laparoscopy. It is good to do laparoscopy. If the gallbladder get perforated, do. Duodenal perforation, do. But if patient is coming after boy prognostic parameter like 3-4 days, already in shock, already has fibrinous cardboard rigidity, looking toxic, and bacteremia and septicemia increases after laparoscopy, because this CO2 will push all the bacteria through the inflamed peritoneum in the circulation. So, chances of bacteremia and septicemia. Do you know when perforation happen? Initially there will be chemical peritonitis, then gram positive, then gram negative, and then anaerobic peritonitis happen. So, if patient has already reached to the level of anaerobic peritonitis, then laparoscopy should be contraindicated. Next contraindication of laparoscopy is previous extensive abdominal surgery. 1 or 2 surgery is not contraindication, like cesarean section was done or the some duodenal perforation, some laparoscopy. But in these extensive cases, where you will put? Palmar point is also bad, no space here to put. All the wounds are healing by secondary intention, not even primary intention. So, previous extensive abdominal surgery is contraindication. This extensive word is important. It is not that 1 or 2 surgery is contraindication. Next contraindication of laparoscopy is previous generalized inflammatory disease or irradiation, like patient has Crohn's disease, ulcerative colitis, miliary tuberculosis, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and previous extensive inflammatory disease. You have an extensive adhesion, or if patient has received any irradiation on the abdominal wall due to any cancer, and like colon cancer or any cancer, and a lot of irradiation is done. Do you know what happened after irradiation? All the areolar tissue plane of the abdominal wall fuse together and it become in leather. It become leathery, abdominal wall become leathery, and then there is a high chance of the perforation of the bowel. So, previous extensive irradiation or generalized inflammatory disease is a contraindication. But remember, again I am telling you many times that these all contraindications are relative contraindication, not absolute. Relative contraindication means suppose patient has any stent applied 5 years ago, but right now patient is good, ejection fraction is fine. Patient has received tuberculosis and it is already treated for 4 months. Now the lung is fine, then you will do laparoscopy. So, severe word always remember, not a simple problem, not just a simple miliary tuberculosis, but it is already treated, then you do laparoscopy. But extensive procedure you should avoid. Now, again another contraindication is hyper or hypocoagulable space. Hypercoagulable like polycythemia. If patient has polycythemia, laparoscopy is contraindicated. Why? Because platelet aggregation is very bad here and DVT chances are more, because all the platelet, because in laparoscopy venous return decreases. So, intraoperative risk of DVT is high. So, any patient who has a hypercoagulable state, they have a high chance of forming the DVT. So, you must treat it first and then you do. And hypocoagulable is also contraindicated. Nowadays, physicians are over prescribing antiplatelet therapy. Like if the patient has any history of cardiac problem, they write aspirin, coumarin, warfarin and heparin or whatever, these type of anticoagulant and anticoagulable antiplatelet. If those patient has received it, you should get PT-INR done. And if PT-INR is a routine test for laparoscopy, and if it is more than 2 international unit, then we should not do laparoscopy. Because in laparoscopy what happened, that during the laparoscopy, if the patient has hypocoagulable state, it will not bleed. Why? Because we have a positive pressure. So, capillary bleeding does not happen due to positive pressure. And once you have removed your gas and you go back home and once all the CO2 absorbed, then again negative pressure of the peritoneal cavity starts, and then rebleeding starts. Because by coagulation we can only stop bleeder, we cannot stop RBC. RBC body is stopping by platelet aggregation, and they have antiplatelet treatment, so rebleeding chances are there. So a patient who has already getting the hypocoagulable medication, you have to stop it for 1 week by the permission of cardiologist. Like some valvular disease was there, surgery was done, or coronary artery bypass or stenting, and patient is taking those medication, we have to stop it and then take the permission of cardiologist. Otherwise, with the active treatment you will do, bleeding will be a lot. And open surgery, bleeding happen in front of you. Laparoscopy, that bleeding happen once you are sleeping at night, because during surgery it will not bleed. So you will think that my surgery is very good, but once CO2 is out, then it started bleeding. In front of surgery it will not bleed. So this is also contraindicated. Advanced stage of pregnancy is contraindicated. Up to 20 weeks of the pregnancy, laparoscopy is gold standard. And this is a very peculiar thing to understand. Do you know, in your professor has told you when to do laparoscopy in the second trimester. Am I right? And he has told you to do any surgery in the second trimester. First and third trimester should be avoided. But this is wrong. This is wrong, and this was done in the SAGES guideline. If you will go to the Society of American Gastrointestinal Endoscopic Surgeon, just you type SAGES and pregnancy. This is the largest organization of the world, that is Society of American Gastrointestinal Endoscopic Surgeon. And they have done a lot of research in the guideline for use of laparoscopy in pregnancy. And according to SAGES guideline, laparoscopy is safe in any trimester of the pregnancy. And this is wrong that we should wait for second trimester. Look at this guideline number 9. Traditionally, the recommendation for non-emergent procedure during pregnancy has to avoid surgery during first and third trimester to minimize the risk of spontaneous abortion and preterm labor. Right? That is what our professor has told us, and this has led some author to suggest delaying surgery until second trimester, and that the gestational age limit of successful completion is 26 to 28. These recommendations are not supported by good quality evidence. Recent literature has demonstrated that pregnant patients may undergo laparoscopy safely during any trimester without increased risk of mother and fetus. So laparoscopy is always safer than open surgery in any trimester, even the first trimester, even the second trimester. Like a patient who is 3 months pregnant, and patient come with the gallstone symptomatic, then you should tell the patient immediately, abhi turat karao, immediately get it done, because once you will become more weak of the pregnancy and then cholecystitis happen, surgery will be difficult. And remember, laparoscopy doesn't increase the chances of abortion. There is no preterm labor, there is no abortion happen, because this 12 and 15 millimeter mercury pressure cannot abort the baby. Another important thing, that this fetal hemoglobin is very smart. They can tolerate the CO2 better than the adult hemoglobin. So you should always, laparoscopy should be done as soon as it. I am not telling about emergency. Emergency, anybody you have to do, like ovarian torsion happen, then immediately it has to. It is for non-emergent procedure. Non-emergent procedure. This is bad that you tell the patient that once you will deliver, pregnancy is over, then I will do. You should do as soon as possible. And in America, any trimester of the pregnancy they do laparoscopy. But in EAES line, after 20 weeks of pregnancy, more than 20 weeks of pregnancy, laparoscopy should be a relative contraindication. Why? It is not because of the fetal death or abortion, it is because of the gutting effect. What is gutting effect? That once the gravid uterus become very big, it pushes all the bowel to the paracolic gutter. उसको guttering effect बोलते हैं. Like suppose you have a uterus coming up to the umbilicus here and you want to do appendectomy and you will put the port, then you will not find the appendix because this gravid uterus will push the appendix to the paracolic gutter. You want to see the ovary is in the ovarian fossa hidden, sometimes compressed by the gravid uterus, and it is very difficult to reach to the organ. So according to EAES guideline and WALS guideline, after 20 weeks of pregnancy, laparoscopy should be a relative contraindication. So advanced stage of pregnancy is a contraindication. In as early you will do, like in cervical cerclage. Previously people were saying that we will do in second trimester. It is bad because if the vaginal cerclage is failed before and you want to do laparoscopic cerclage, you should do as soon as it is possible. If you will delay, gravid uterus will be very vascular and very difficult to reach to the cervix and get a Marceline tape. But the problem is patient is waiting for second trimester. By some gynecologists they say that second trimester only we will do. So don't do that. Do as early as possible, then it is safe. Now, suspected carcinoma is a contraindication. You know, known case of carcinoma is not contraindication. Like you know that there is a cervical cancer, you can do radical hysterectomy. You know that there is a rectal cancer, you can do low anterior resection. You know that there is a gastric cancer, you can do complete gastrectomy. Esophageal pull through for esophageal cancer, and it is benign, you do it. But if it is a suspected malignancy, you are in trouble and you should avoid laparoscopy. Like it is a mucinous cystadenoma and CA125 is raised and you have a suspicion that it may be endometrioma, it may be mucinous cystadenoma, and it may be borderline mucinous cystadenoma, it may be mitotic type 1 mucinous cystadenoma. And then if already you know it is cancerous tumor, then you will do ovarian cystectomy or you will do oophorectomy. Then it is allowed because you will not spill any fluid. You will go with the IP ligament, you cut the entire ovary and you will do en bloc dissection together in the endobag. And if you think that it is benign, then what you will do? Ovarian cystectomy. But if it is malignant and accidentally you did ovarian cystectomy, then what will happen? There will be spillage and metastasis. Remember that even if you put the endobag, can you order each and every drop of fluid that you must have to go to the endobag? I will kill you if you go anywhere else. Because it may sprinkle little bit and some fluid may enter into the abdominal cavity. Am I right? Even in open surgery, sometimes spillage happen. General surgeons, they want to take sebaceous cyst very nicely out and it ruptures. Isn't it? Instead of all the precaution, it ruptures. Same way, even open hysterectomy, it ruptures. Open abdominal hysterectomy. So, if spillage happen and metastasis happen, it is considered as a medical legal. In 2014, one of the very good cardiothoracic physician was there in America. His wife was operated for supracervical hysterectomy. And in supracervical hysterectomy, always we have to use morcellator because there is no way vagina will not be opened at all. So morcellator was used and then sarcoma developed. And after that severe metastasis developed and she died. After that this physician, cardiac physician, has sued the morcellator company, Johnson & Johnson. He has sued the gynecologist, surgeon, everyone, but sued the morcellator company also. And then Ethicon has to recall their morcellator from all over world. Ethicon recall morcellator, and you know they have to lose millions of dollars loss was there. And Gynecare morcellator, and you can see here class 2 device recall. And Gynecare, Johnson & Johnson withdraw the morcellator market, power morcellator, citing risk of malignancy. and laparoscopic power modulator recall. Lawsuit were filed, uterine cancer was there in 2014 June, and it was order was given by the court and FDA, and power modulator was recalled. And they were selling a very good power modulator that was called Gynecare Morcelex, and this is Gynecare modulator, and this is the Gynecare modulator. This is very good modulator here. This is Gynecare Johnson and Johnson, and they have to withdraw it, and they have millions of dollars of the loss, withdraw modulator market, and all over world they have to withdraw. They come to us also, and they told that, sir, we want modulator back, and then we say that our staff, I don't say, our staff say that we don't remember where it is, come next time. And they came next time, yes, now give, and we didn't give. We say that we forgot where it is, so come next time. Because we don't follow the SAGES guideline or American FDA rule. In India, if you will follow FDA rule, you cannot operate. Am I right? So we are using modulator. But actually suspected malignancy, it is a contraindicated. You should do either open or consider it as a malignant. And if metastasis, port side metastasis or abdominal wall metastasis happen, it is a medical legal issue. So suspected malignancy, laparoscopy will not be performed. This suspicion has to be correct, confirmed, yes. I am not saying don't do malignancy, because once it is malignant, your consent will be different way. Your consent will be that there is no guarantee made that my malignancy will be completely cured and my situation may be worse after surgery. यही लिखा रहता है. In the malignant OT note, on the bottom it is written that after surgery my condition may be worse than right now. But that type of consent in benign you cannot take from patient. So this is contraindicated. Next contraindication is the gas aerosol jet stream is a problem. So you can see a lot of gas is coming out. So a patient which is a viral disease, HIV, hepatitis B, you should get viral load. Always measure the viral load, otherwise treat for HIV first. Or if COVID, active COVID, use HIV first. And if patient has viral disease, use your glass protector or good quality of the mask, that is 99 mask you have to use, because if there is a pneumoperitoneum and there is a compressed gas and there is a interior milieu, so those viral DNA, bacteria, carcinogenic material, and it will hit to your nose or eye, you may be trapped by the HIV or hepatitis or COVID. So any patient who has COVID-19 active disease or HIV active disease, laparoscopy is because little leak of the CO2 is always there. When you put the cannula also, little leak is always there, and that leak of the aerosol is dangerous and we should avoid. So this is one of the contraindication. Now there are few specific indication of laparoscopy, where laparoscopy is the first line management, like cirrhosis, sickle cell, HIV and ectodermal dysplasia. In cirrhosis patient, laparoscopy is very good because laparotomy can create wound descent. Sickle cell disease, laparoscopy is considered better than open, because sickling crisis, if you search in the Google that laparoscopic and sickle cell, they say sickle cell patient, laparoscopy is gold standard. HIV patient, for you it is little risky, but for patient laparoscopy is gold standard, because patient is good, because patient has an advantage that he will not have further immunosuppression. Am I right? If he will go for laparotomy, he may not die due to cholelithiasis, he may die due to, yes, due to the cholelithiasis he will not die, he will die due to the wound infection. So HIV patient, it is gold standard. There is one HIV hospital in Ahmedabad, and their entire team of once approximately 10 years ago, all the gynecologists and surgeons government has sent to us for laparoscopic training. At one batch there were one hospital, 20 surgeons they came, and since that time they are doing laparoscopy day and night. There is no problem in laparoscopy doing for HIV. because this Sidex which we are using, it is a very good virucidal agent. Virus it kills very fine, very nicely. But you have to take care of your own protection, like a proper shield should be used, proper gloves. But because it is interior milieu, your hand is not inside, your hand is outside, so that way you are safer than open. Because you are directly not cutting any tissue, your energy is cutting the tissue. But then also aerosol is a problem that you should take care. But for patient it is gold standard. Ectodermal dysplasia is an autosomal disease in which there is less hair follicles and sweat gland in the skin. Those patients after open surgery, they have a high chance to go to the hyperthermia. So doing laparoscopy to those patients, they can well tolerate it. And that's why these are the surgery where laparoscopy is first line. The open surgery should be the next option. So ultimately, if you will see risk versus benefit, then it is little risky surgery compared to benefit. Complication rate of laparoscopy compared to benefit is slightly risky. Like, you know what is the CBD injury complication rate in the laparoscopy is 0.5%. In open it is 0.1%. Ureteric injury in American Journal of Obstetrics and Gynecology in 1998, when they did a study, 4.3% ureteric injury in TLH. In the NDVH it is less than 1%, non-descended vaginal hysterectomy. Am I right? So that way if you will see, it is risky surgery. Complications rate are relatively high. Then you will ask the question that then if it is risky, why we are doing? Because you are forced to do by industry. It is industry driven surgery. Industry will force you to do. And another, that in the people in whom laparoscopy is successful, their quality of life comparatively very good compared to open surgery. So that's why this little risk is taken. In spite of this risk we are taking on the cost of outcome. Just like what is the most risky thing in the world to do? What is the most common cause of unnatural death in the world is accident. Do you know accident in 1 year the people who they killed, that is more than the number of the people who killed in the Second World War. Every year we are killing in the accident those many number of people. And most common cause of accident is road traffic accident. But can we stop road traffic? Can we stop traveling? If you don't want to die due to accident, go in a beautiful jungle and make a hut and stay there. And there will be no any problem, no accident can happen. You will be near to nature. However, tiger can come and can eat you, but at least you will, the road traffic accident will not happen. But are you taking this? You are taking this risk because your quality of life is good. You are going to different country, different hill station and taking this risk because quality of life will be better. So little risk. And if you will do the control environment, risk assessment, control activity, and most important is monitoring. These are called internal control component. That is management objective, then risk can be minimized. And most important thing in laparoscopy is patient selection, whom not to operate, because you have to enter into the abdomen at your own risk. So you must be knowing that whom not to operate, because every patient is not a good candidate for doing laparoscopy because of the problem of the pneumoperitoneum, and it is a minimally invasive surgery. Laparoscopy is not a surgery in reality. Laparoscopy is a surgery over image. It's a virtual surgery. So once you are doing virtual surgery, then your patient must be fit for tolerating this surgery. So thank you very much. This was just the past, present, the disadvantages and contraindication of the laparoscopic surgery. If you have any other question, we can discuss.